Okay, my name is Ian Rummery. I am mental health team lead and community psychiatric nurse for the island of St. Helena in the South Atlantic Ocean. Briefly, St. Helena is a British overseas territory, population just over 4,000, kind of halfway between Africa and South America, very remote. A weekly flight if it gets here, though last week's flights only turned up yesterday. Because the wind was a bit blowy. It's quite a difficult place to get to. So as I said, I manage the mental health team. So the mental health team on St. Helena is 3 community psychiatric nurses and a support worker, like a healthcare assistant. We have then a psychiatrist who's based in Scotland. So we have remote support from her, which is every 2 weeks we have sort of a virtual ward round, and then we're in email contact, and she will see patients for us. Previously, we had, for the last 5 or 6 years, we had a psychologist on island. We've now made the decision because of the difficulties in recruiting, so all of our psychology services are remote. We have a main counselling psychologist based in Cape Town who sees on average about eight patients a week. And then we use other specialists as required. I've been on St. Helena for 20 years, my son is 20, so 21 years now. My wife is St. Helenian, and we came out here in 2003. Prior to that, so I trained as a psychiatric nurse in Australia, did a bit of work in Australia, then moved to UK, because I'm British by birth, jobbed around a bit, and then in 1994, for whatever reason, I still don't know why, I'd always wanted to go to St. Helena. Back in those days, there was no airport, so it's a 2-week journey on a ship from Cardiff. Belinda, who I'm now married to, was on the same ship, and I was supposed to see St. Helena and the rest of the world. I only saw St. Helena. Came back to the UK. And then spent the next probably 8 or 9 years trying to convince Belinda to return to St. Helena, which we did, like I say, in 2003. And then since then, so on St. Helena, my first job was really running the older person service. We built a new nursing home and managing that. I had a bit of I call it my midlife crisis, when I gave up nursing for about 9 months and went to work for the Environment Directorate, and then realised that filling out log frames and Excel spreadsheets was not my thing. Then got elected to the local council for about 18 months and realised that was just doing my head in, and luckily got back into psychiatric nursing. So that's where I am. We are literally cradle to grave in terms of what we do. So we see everything from people in emotional distress following the breakup of a relationship, right through to people with quite severe mental health issues. And a particular sort of specialty or particular interest of mine is forensic work. So in the last couple of years, I've developed the police custody system. So we now have quite a robust police custody health assessment service. And I also act as the prison nurse. And in the prison, we do both physical and mental health. So it's very likely, because I've just seen someone in police custody who's probably going to get remanded to prison this afternoon. It's very likely that when I finish here, I'll go back down the prison to then book him into prison.
And that's how we, sorry to interrupt you, Florian, but that's how we met, isn't it? Through that forensic interest. So Ian and I have met before. I'm Rachel Forbes, consultant in public health and assistant director at North Lincolnshire Council in England. We met through the Global Law Enforcement and Public Health Association, through Nick Crofts, who's the exec director, introduced us because he's aware of the work that I've been doing with Rachel Westbourne on social love, and also aware of the work that you've been doing on St. Helena, which is very similar and has so much crossover. So we've had a chat before, and that's when I knew that we needed to speak to you and record it so that other people could hear about what you're doing, and also about how what you're doing is really relevant to social love and public health. So tell us a little bit more about the prison system, just because I'm really interested to hear it again. And
so I've just come back from Pretoria, where we went to the African Law Enforcement Public Health inaugural conference. And I gave a presentation there with my son, Tobias, who's a police officer. I'll send you guys, we just got it uploaded to YouTube, so I'll send it to you later.
Brilliant.
And basically what we did was we gave a presentation, we called it Calming the Chaos, working with law enforcement to promote mental health recovery. And what we did was we took a case study of a young man. It was largely based on one young person that was kind of anonymized and whatever. But basically the gist of the presentation was, it's a young man who'd been in and out of trouble with sort of various low-level graffiti offences and all sorts of other things. Then he gets arrested for an assault, quite a serious assault, potentially a custodial sentence. And through the custody service, so through the fact that we have a decent custody suite, the fact that we use PACE, the fact that we follow the rules, that this young man then actually said, you know what, actually, no, you're right, I need some mental health support. He wasn't mentally ill, but he had some significant adverse childhood experiences, attachment issues, all the rest of it. So what's happened is we managed, with the assistance of probation, the courts and police, to divert him away from court into probation and mental health treatment, and he's doing, touch wood, quite well at the moment. So that was sort of the gist of our report. It's a very old prison. It was built in 1826. It was condemned in 1850, and we're still using it. It's very small, very cramped, smack in the middle of town. Having said that, it's quite, I wouldn't go so far as to say it's therapeutic. However, because it's a very small prison and because it's a very small community, it's also a very relaxed, not relaxed is the wrong word, but it's a very calm prison in that respect. So I have, in the 5 years I've worked there pretty much continuously as part of my other work, I've witnessed 2 episodes of violence. Wow. And both of those were very, very low level. I've never felt threatened. I can walk around the prison unaccompanied. I can pop in and out and see prisoners. Yeah. Our prison capacity is around about 25 at the moment. It's around about 18. Of those 18, off the top of my head, I would say 12 to 13 are sex offenders. We have a number of people with historic sexual offences dating back 20 or 30 years that were only imprisoned in the last year or two. And, you know, often, certainly some of our St. Helena prison officers are related to these prisoners, you know, cousins, uncles, whatever.
Remind me what your population size is.
So it's about 4,200. Yeah.
4,200.
It's also quite, and I suppose this is the difference when we compare us to Montserrat, is we're a very aging population. So it's something like 25% of the population is over the age of 60. Okay. So we have real issues with an aging population. You know, our nursing home, yeah.
You said last time we spoke about younger people just moving away for jobs and other opportunities, and because it is such a small island. Tell us a little bit about the island itself and what things are like there. And you said about the flight, you know, the one flight a week was still.
So it's a volcanic island, so it's quite steep. There's really only 2 or 3 access points that you can actually get a you know, there's only one beach, which isn't really a beach, not by Australian standards anyway. So it's a very, so up until, 2016, I think it was a ship, it was one ship, so that would come in about once a month from Cape Town. It is the same ship that I got. What happened was back in 94, when I first came out here, the ship used to come back to the UK as well. Then they stopped that, so it was just going St. Helena, Cape Town and back again. About 2016, they built an airport. The first commercial flight that came in almost crashed. So then the airport shut down for a while they had a bit of a rethink as to how they were going to do things. So we now have a weekly flight Airlink from Johannesburg. But it's incredibly weather dependent. So I would suggest you YouTube St. Helena Airport and just see, because literally the runway is 1,000 feet up and it's a cliff at either end. Literally the runway goes from one edge of the cliff to the next.
Wow.
So the plane that came in yesterday, and this is probably the record, took 5 goes to land. So it came in, it touched, it took off again, it went round, it waited, it came back in again. I reckon if they hadn't done the 5th one, they'd probably had to fly off to Ascension Island, which is 700 kilometres away, to land. So,
wow.
And actually, if you watch the video from yesterday, it looks like a perfectly normal day. It's not particularly cloudy, it's not wet, but the wind is just howling through. And because you're 1,000 feet up, and there's lots of, I don't know, lots of technical wind shear things and all sorts of stuff. But obviously, yeah, it can be. I mean, I flew back from Pretoria, 2 weeks ago, and yeah, it was a bit, because as you're flying in, you suddenly just see the runway. And of course, we know how long the runway is. It's not very long. So if they don't really have a lot of room. So, you know, when I was watching the video of the plane that was kept aborting its landings yesterday, you could see they were just too far down the runway, but they've had to come in quite high. So, you know, that's normal for us. So, it's, you know, it's quite normal that we're cut off. It's quite normal that the ship gets delayed. It's quite normal that we run out of butter or margarine or potatoes. Never cigarettes or alcohol, strangely enough.
That's funny.
Interesting.
So, you know, when the whole world got cut off for COVID, it was kind of like, yeah, so what? You know, this is kind of how we live. We got through COVID
that didn't really change day-to-day life.
What we did, well, it changed because we couldn't get flights from South Africa, so we had a charter flight from UK every 6 weeks. And we went through a whole thing of it. Initially, it was quarantine for 2 weeks, and then we went right through. And again, yeah, that was disruptive, but, you know, actually no one on St. Helena died of COVID. And we were 96% or 97% vaccinated.
Wow.
And I think that also speaks to the community culture, because I've been having obviously lots of conversations with public health specialists and various people, and it's a bit, you know, there was no indigenous population in St. Helena. So prior to discovery 510, 15 years ago, whatever, there was no one here. So there's been waves of different migrations. And if you know, I know St. Helenians, you know, my wife, for example, to use that awful apartheid term, would be classed as like a Cape coloured person. You know, she walks through Cape Town, people think she's related to them, kind of thing. There are St. Helenians who are very dark skinned, very, very West African looking. There are St. Helenians who are very Oriental, Chinese, Malaysian looking. And there are St. Helenians who look like I do, white, Western. So it's a real melting pot, because at the height of the British Empire, we were kind of the service station in the South Atlantic where everybody stopped. But also what it means is it's a very Western culture. It's a very British culture in many respects. There are interestingly little African sort of, I don't know what you call them, cultural things that run through the community, but by and large we are very British, and that kind of very very, very Western. So, you know, when I was talking to the public health specialists about why we're vaccinated, there's no alternative medication, there's no alternative cultural system for vaccinations. You know, there is no, we are very Western. We operate a community mental health team the same as we operate in the UK or Australia. Like I said, there's no indigenous population. But there's also, like a lot of very remote places for young people, you know, wages are very low. So average wage here is about £7,000 or £8,000 a year, which, when you consider that everything is imported and then taxed again, means it's quite difficult to live here. And what then happens is, so you don't, the divide on St. Helena is between what we call TCs, and so TCs are technical cooperation officers. So they will come out often from the UK. So, for example, you might have a staff nurse in the hospital on £12,000, and you'll have a TC nurse come out on £30,000. plus a £15,000 a year supplement. And that can create, so that creates a lot of, so, and the other thing is that obviously the Falkland Islands, which is part of the South Atlantic British Overseas Territories, they are raking it in. And so if you're a nurse on St. Helena, on £12,000, you could probably go to the Falklands and clean toilets in the army mess for £20,000 a year, you know. So we lose an awful lot of people. Yeah. It can be quite difficult. And also it's just that, you know, I finished my school in a small Australian country town. I was desperate to get out and go to the city. So, you know, like my son, he's a police officer here. He will probably next year leave and go look for further things. So the islands are always on a bit of an edge. Like, we don't have enough staff at the hospital, we don't have enough staff at the nursing home, we don't have enough staff in the police. So we're always struggling, and can become quite difficult because we are quite, in the sense that we are quite British, and we are quite, I don't know how to say this, law abiding in that respect. So for example, we don't cut corners. So even though you know, our judicial system is really quite robust, so even though we might be short of police and we might be short of that, there's you know, they still do their job. And we still do our job. So it can be very, very, so it's not that we're not overwhelmed by numbers of people, but the pressure here can be quite, you know, we had a person who got brought to hospital early part of the week who'd had an overdose, and we knew who he was, but he wasn't one of our patients. But I ended up having to call sort of our support worker who was on leave to come in to sit overnight because the hospital didn't have enough staff to keep an eye on him. We weren't hugely concerned in the sense that we didn't, but at the same time, you've just taken an overdose, you're on drips and God knows what else. We can't leave you by yourself. And I think there is that kind of thing where we will, as a community, as professionals, we can't just say, no, we can't do it. And if she hadn't done it, I would have done it. One of my other colleagues would have done it. And it would have meant that there would have been a huge, the reason I was grateful for my support worker coming in was at least then it didn't have that impact. Because if I'd worked that night shift, then all of that stuff I'd have to do the next day would have just been cancelled. And that would have caused then a further knock-on effect because I had patients to see and doctors to talk to and stuff like that. So we've recently had a guy who's managed to successfully sue the prison, and it's in the public domain now, because we don't really have an exercise area in our prison. There are some significant concerns about fire risk, and he's successfully sued, and I don't know what kind of pay he's going to get. And yet, if you said to me, Ian, we're going to put you in prison and you can go to HMP Jamestown and St. Helena, or we'll send you to Wormwood Scrubs, I'm coming to Jamestown. You know what I mean? It's, when I compare, and yes, our conditions are not great. We're not at all minimising the difficulties of our prison. But when I hear some of the stories about UK prisons, or Australian prisons for that matter, I think, the infrastructure is very poor. But the actual care and welfare of the prisoners is really quite important. And that's the same in police custody.
Yeah. So despite all of the challenges that it sounds like can come in living on St. Helena with the small and ageing population, being kind of quite isolated in some ways, there's still something that has allowed a really kind of like positive and safe culture in some aspects to develop. And what do you think it is that has helped to promote that?
I'm not sure. I mean, it's difficult because, like I say, I've been in police custody today, and it's unusual that we get 2 arrests in one day, but they're both for sexual assault. I think there's a couple of things. I think one is that a good portion of our, let's be honest, most offending is 18 to 25-year-old males. A good portion of our 18 to 25-year-old males are just not here because they're on. So to the north of us is Ascension Island, which is nominally a UK overseas territory. It's effectively an American Air Force base. And so lots of people go there to work, and obviously lots of people go to the Falklands because there's loads of money on the Falklands. So I think there's a bit of that. I do wonder, and I have no evidence for this at all, but I do think that the St. Helenian male culture, and I got to be careful because there are still very high rates of sexual assault, is not the macho culture that I would expect from an Australian country town, for example. So anecdotally, I think we have fairly low levels of violence. So, I'm pretty sure in an Australian country town, every Friday, every Saturday night, at closing time of the pubs, there are just people brawling in the streets. It's just kind of a common thing. It's very rare that happens here. So I think it's not a particularly violent society in that respect. We're also lucky in that there's no real drug problem here, simply because it's just too hard to get. There has been some. We are thinking there might be some fairly novel drugs that come in because there may or may not, one or two people may or may not have drinks spiked the last couple of weeks. We're not really sure what's going on there. But if you couldn't maintain a cocaine habit on St. Helena, for example, because you just couldn't get the supply. A lot of marijuana, a lot of cannabis is smoked, and there's a small sub-reggae culture on St. Helena. But what's different about us? It's very hard to say. Yes, we're a very small community. I think that the interesting thing, I would also say that St. Helena is probably the smallest, I want to say, remote society in the world, because if you look at, so yes, there are more isolated islands. There's Tristan da Cunha, which is British. There's Pitcairn. There are isolated islands, all over the world, but they're by and large either have a strong indigenous population or they have a strong family. So Tristan da Cunha, which is further south of us, is another British territory, has a population of about 280, but it has about maybe 3 or 4 families dominate that island. Whereas St. Helena we're small enough that a lot of us know most of each other, but actually we don't know. It's not that kind of really, really small village.
Yeah. So
maybe it's that, yes, we are insular, but we're not that insular. I don't know.
Yeah. Island. Could you tell us more about the work that you've been doing?
Yeah. So, and I think this is where, Rachel, we had that conversation last time, is, so yeah, I might be the psychiatric nurse, and yes, I do all things psychiatric nurses do. So I give medications, I'm not a therapist, but I'll do kind of basic counselling, whatever. I'll also take people shopping. I'll also organise doctor's appointments for them, go to doctor's appointments with them. I had a phone call this morning. I got a phone call first thing this morning because one of my used to be in prison ex-patient has a bit of a drinking problem, wants to come into town for Christmas. I'm going to pick him up tomorrow morning and bring him into town. I'm also going to make sure I take him out of town before the end of lunchtime. Otherwise, I'm pretty sure he'll be drunk and then probably get himself arrested. Or what will happen is the police will ring me and go, we really don't want to arrest him, so can you please just take him out of town for us? And I'll drive him back to his place in the government vehicle. So we do a lot of things. Like I said, we do a lot of teletherapy here. So after getting called into police custody this morning, I then had to drive out to pick up a patient to bring them in so they could sit literally at this computer and have their counselling session with the psychologist in Cape Town. There's no public transport. We got him in on time. He doesn't have enough money. As far as I'm concerned, I'm not just picking him up and driving him here. I'm also having a conversation with him. We're also having a chat about, because he's someone who has disclosed, so he's disclosed some historic sexual abuse, and 2 people have been arrested. And so we're talking about that case while we're driving in. So we do a lot of those kinds of things, which to me are absolutely vital to building the therapeutic relationship. I would, and I think I said this to you, Rachel, I would really struggle if you put back in the NHS because I break boundaries all the time. you know, in terms of visiting people at home, chatting them at home, taking them shopping, having coffee with them, you know, bringing their mother into, I don't know, just all sorts of different things that we do that aren't technically psychiatric, but I think build that whole relationship. You know,
you're taking the, you know, that you'll have heard of the building blocks of health, or the wider determinants of health. So when we think about the building blocks around housing and transport and family and friends and community, you're sort of enabling all of that. So when people need their building blocks strengthening to be healthy and live a good life, you don't just look at the one thing. You're not siloed. You're working across the whole spectrum of what a person needs. And that to me is just exactly what is needed everywhere. I don't know. What do you think, Rach?
Yeah, it sounds like sort of a truly holistic approach, which is, you know, a concept that we have here and talk about, the idea of holistic care and addressing people's sort of wider circumstances as part of their, like, trying to improve their health outcomes. But it sounds like you're doing that in like a really genuine way. You are not segmenting off someone's kind of treatment from the rest of their life.
Yeah, and I think, you know, and I'm very clear, and I don't know whether this is just because I happen to be the mental health team leads, and because it's a small team, I can kind of influence it. But I am very, very clear that we have a literally open door policy. So you walk up those stairs, if we're here, we'll see you. And I struggle, I don't know who's going to hear this recording, but I do sometimes struggle with our social services department, because they will insist on a referral, and they will insist on a form, and they will insist on this, and then they've got to wait for the case to be open and someone allocated. I can't be bothered with that bullshit. You know, if you're in distress, we're going to come and see you.
Yeah.
And I think, so when, and we've just had a new CPN come from UK, and she's fantastic. And what she said to me was, when we interviewed her, was she said, you know what, I'm sick of working in the NHS and being told I've got 6 sessions and that's it. And if they come back for the 7th session, I've got to re-refer them. I said, look, you can do what you like, in a sense. You can do what you like with your patients here. So what she's discovering is, because she works with some of our more troubled younger people, is, you know, she can go for a walk in the forest with them, or she can take them for an ice cream, or she can do this kind of stuff. And there's no pressure to finish the work. Because, yes, we are busy, and we are, you know, we're all working 40 plus hours a week, and someone's always on call. But we're also not overwhelmed by the numbers of people.
Just on that point, on that, the permission that you've given there to that member of staff, you're providing the freedom for people to know, to do what they know is the morally right thing for the good of that person. And I think that's one of the linkages with social love that really sticks out for me, because social love's all about decision making. We've explored it in a public health context and at a population level, but what you're doing is at the individual level, and it's all about decision making for the good of another person, for a community, for the environment. And that's exactly what that is. It's the right thing for that person to take a young person for an ice cream and go for a walk, rather than have them in a stuffy office talking about any of the issues.
Yeah, and I think too,
you're about value. It's like you focus on value, not process, and on outcome, not process. And that's something that we talk about sometimes in the UK about, you know, doesn't matter what hours you work as long as you get the work done, but then it does, because the policy says that you've got to do X, Y, or Z, and if you're not doing that or filling in your flexi form, like you're potentially in trouble. Bit of a simplification there, but you're treating your staff and the people that you work with like human beings who have a wider life that impacts on the reason that you're interacting with them, whether that be as a manager or as someone that's supporting them, or as someone who's giving them help when they're in prison. And that connection, I mean, what do you think, Ian, about the, you know, from what you've heard and read about social love, because I know you've seen the paper, what has stuck out for you when you've been thinking about the crossover between the two, and how what you do is similar or different from what we were talking about?
Yeah, I mean, I think the thing is, and it is hard because I don't know what we do, and if it goes down the avenue of social life, can it be replicated in a larger organisation? Because I'm well aware, like I say, that we have the freedom to do what we do, and I think we as nurses are working at a quite advanced level, have a lot of autonomy, and that's largely because my medical colleagues can't spell psychiatry, let alone do it, and they're quite happy to leave us to it, and also psychiatry, I think, and mental health lends itself to this kind of thing. So, you wouldn't be able to have this kind of attitude if you were the theatre team, because, you all need to rock up at the same time, and you need to, it's very task oriented. So I'm well aware of the fact that I'm lucky I'm working in an area where it's all shades of grey. There's no real black and white in mental health in that respect. I suppose when I read the social love literature, it's how much of this is dependent on individuals doing what they do because they're passionate about what they do, and how much of this can be institutionalized, for want of a better word, or formalized. But then if you formalize it, are you losing that aspect of social love? I don't know. That's the bit I'm not sure. How do you, how if you whatever the word is, policyfy it? If there's a policy on social love, have you then taken the guts out of it? I don't know. That's the bit I'm not sure. Or do you then create an environment that allows people to be more flexible and more autonomous? Is that the way you do it? And not everybody will do that, obviously, because we're all different. I don't know. I mean, that's the thing for me.
I think you've brought us to a really good point, Ian, and I could talk to you about this all day. What you've just said there about do you lose the social love bit? I mean, for us and in our definition, there is some affect in there. There is some emotion in there, and like you said, if you have a framework, do you create the conditions in which people can make those decisions? And actually, in a later recording, Rachel and I are going to be talking to some people from North Lincolnshire Council who are actually doing a lot of this already. There are lots of organisations in the UK that we're coming to hear about that aspects of their work are socially loving. They're making decisions and putting them through the filter of, is this in the best interests of this person, as well as the community, as well as the environment? And that's what we're after, really. And I think you do that, but it isn't formalized. And I'm really interested in how that formalization would affect or could affect what you do. Rach, what do you think? Because we have got to wrap up very shortly.
Yeah, I think that's a really kind of good conclusion, like a good concluding reflection, I suppose, because for us, I think partly because of the system that we're working in, policies and processes do determine so much of what happens, and they kind of almost set the scope and the boundaries for what can happen, for the culture that follows, for how the workforce behaves. And so that feels like a really important thing to do. And we think that a lot of our policies and processes and systems at the moment probably aren't socially loving or don't allow for like the promotion of a socially loving culture and environment. So we've been trying to think about how do we alter them so that they would promote that. But it's really interesting to think about, if you do try and formalize some of these things, what might you lose as well?
And also, where do you, how do you make that a system that's both flexible enough so that we could do the social love stuff, but also has significant safeguards, that it's not just a free-for-all?
Yeah, exactly. What I was going to say is trying to reach that balance, isn't it, between the sort of safeguards that we absolutely need in place, but also allowing a flexible and an adaptive approach, which it sounds like is what you and your team really have. You can be adaptive and you can be flexible to meet whatever the needs of the patient are, which is really important for actually providing that holistic care that addresses social determinants that we were talking about. You can't do that if you're working really rigidly, but obviously you do still need certain safeguards, certain safety procedures still in place. And it's interesting to think about, how do you find that right balance? And that probably feels like it is easier to do in a smaller team and a smaller community setting like what you have.
All right. Thank you, Ian, so much for talking to us again, talking to me again, and talking to us together. It's been really interesting, and I love hearing about island life. I do. I could. I'm not sure, because Rachel and I have talked about how we have a community of interest or a community of practice, and maybe it could be a special interest group under GLEFA, but then it would have to have the law enforcement link, which I think it does. But so as far as we've got at the moment is Rachel's creating a Knowledge Hub site. Do you have access to Knowledge Hub, Ian? Have you heard of it?
It's a open access website, so in theory you should be able to access it. But we're trying to set something up that can be like as open as possible, because we want people from anywhere in any setting to be able to join it, which means it's probably going to be something a bit more like informal potentially, rather than under a particular network.
We've explored.
We are trying to establish something.
But we both have. So Rachel, just introduce yourself as well, because I think I missed off you introducing yourself, to say we are.
So I'm Rachel Westbourne. I'm a specialty registrar in public health.
So yes, we both have full-time jobs as well as doing the social love stuff. And I for me at North Lincolnshire, I have loved. I mean, this is my first consultant post. I started there in July, and the first 5 months has been a real whirlwind. We're recording this in December 2024, and everybody is so proactive and passionate, and there are so many socially loving decisions being made, and so many people talking in a public health way, in public health language, and it's blown me away, honestly, and I'm very pleased and proud to work there. So I think the more we've discussed social living in various forums there, and have looked at how we formally incorporate it into strategies and policy. That's what we're exploring now. So I think as that progresses, there might be a possibility to do some more of that as part of the day job. But at the moment, for both of us, it's a bit of a side passion that we're following. But
once a week, and it's not. We're back to the social life. It's about the relationships that we develop, and it is, and it can be quite difficult. Like I say, I'm potentially going down this afternoon to book in a prisoner. I know full well the impact of his offending, because I'm also not directly treating the survivor, but my colleague is, and I'm supporting her in this. And and actually, yes, yesterday I picked that woman up to bring her into the office to attend a meeting, because she couldn't get in the other way, and my colleague was busy doing something else. And also, I think part of it is, indirectly, I kind of also want this woman to realise that not all men are bastards. You know what I mean? It's like she's had some horrendous experiences, but I also want her to know that she can feel safe sitting in a car with a male and driving down to the hospital. I think that's important for her recovery. Is that so it's all very complex. But it does come back to relationships. I think that's the key. And maybe that's it. How do you create an environment that allows you to foster those relationships, so that we're not like my colleague who was just, you got your 6 sessions and that's it. And you can't do anything else, and they've got to be seen in this office, and you can't do whatever. How do you develop that system that allows these relationships to develop, but still safeguards, so you don't have people taking advantage? Because let's face it, all of the people I work with by definition are vulnerable. But how do you give that freedom to, as you said, make those social love decisions?